Am I audible, sir?
Yeah, yes, you are audible.
Good afternoon, respected faculties. So today we'll be having the seminar on temporal mandibular joint and orthodontics. So going to the contents of the seminar, so we'll be talking about the embryology of the temporal mandibular joint, the anatomy of the temporal mandibular joint. Then we go to the history of temporal mandibular disorders, its etiology, prevalence, the temporal mandibular disorder diagnostic categories and its diagnosis. Then we go to the imaging of the temporomandibular joint, screening of the temporomandibular disorders. Then we go for the protocol for the management of temporomandibular disorder. And then we'll talk about the occlusal appliances used for the management of temporomandibular disorder in orthodontics. And we'll talk about the hypothesis for the occlusal appliances. Then finally, we'll talk about the review articles and finally the conclusion. So going to the embryology of the temporomandibular joint, the temporomandibular joint develops between 8 to 14 weeks, whereas in comparison to the other synovial joint, which generally develops between 5 to 8 months, 8 weeks, 5 to 8 weeks. So the temporomandibular joint, this is found between the articular surface of the temporal bone and the condyle of the mandible, and the articular surface of the condyle of the mandible. This is generally formed by the fibrocartilage. And the components of the TMJ includes it has bony components, the soft tissue components. It has the muscles of mastications are attached to the to the temporomandibular joint, and also it has the arterial and nervous supply to the temporomandibular joint. And in the bony components, it includes the glenoid fossa, the articular eminence, the condylar head, and in the soft tissue components, it includes the articular disc, the joint capsule, and the ligaments. And in the muscles of mastication, it includes the temporalis, masseter, medial, and lateral, and it has the arterial and the broad supply, knob supply. So the temporomandibular joint, it has the articular disc, which is interposed between the temporal bone and the condyle of the mandible, and in this articular disc divides the condyle into the upper compartment and the lower compartment. And the function of this upper compartment is that it helps in the translation of the joint, whereas the lower compartment helps in the rotation of the joint during the opening and closing of the jaw. And the load-bearing surfaces of the condyle, these are avascular, and also they are not innervated, and they are lubricated by the synovial joint. And the amount of synovial joint in the upper compartment is generally 1.2 ml, whereas in the lower compartment it is generally 0.9 ml. So the articular surface of the TMJ, these are generally covered by the fibrous connective tissue, and this is in contrast to the other synovial joint, which are generally covered by the hyaline cartilage. So this is the articular disc. This is the condyle of the mandible, and this is the posterior attachment of the articular disc, and this is the anterior attachment of the articular disc. And the anterior attachment of the this articular disc, has the attachment to the lateral pterygoid muscle. So the posterior and the anterior attachment of the articular disc, these are generally composed of the loose fibrous tissue, and this posterior and the anterior attachment, these has the vascularity as well as innervation. Whereas the middle portion of the articular disc, these are basically avascular and are also not innervated. And also this is the thickest portion of the articular disc. So the soft tissue component of the temporomandibular joint is that it has the TMJ temporomandibular joint capsule. So this is the temporomandibular joint capsule, and it surrounds the joint and is attached above to the squamous bone around the margin of the upper articular surface, and below it attached to the neck of the mandible. And also the lateral pterygoid muscle is inserted into the anterior surface of the capsule of the TMJ. So talking about the other soft tissue component, that is the articular disc. It is a plate of the fiber cartilage which divides the joint cavity into the upper and the lower compartment. And this articular disc, in the middle and the lateral aspect, the articular disc bends to the capsule of the joint, and whereas in the front of the articular disc, it is attached to the capsule as well as the lateral pterygoid muscle. And in the posterior section, the articular disc divides into the upper and the lower layer. And the upper layer is attached to the upper layer of the posterior disc. This attached to the squamotympanic fissure, whereas the lower layer attached to the posterior surface of the neck of the mandible. And this articular disc, when viewed from above, this is slightly concave anteriorly, whereas it is convex posteriorly, and whereas in the undersurface of the articular disc, this is concave to the whole extent. And also this disc is not uniform, and the center part is this is thickest and it's relatively avascular, whereas the other part of the articular disc is they are vascular and innervated. And also the articular cartilage and the center part of the disc also contains no nerves. So this is the articular disc, and the upper part of the articular disc, it is concave in shape, and when we go posteriorly, it is convex. Whereas the lower portion of the articular disc, this is concave throughout its length. And the posterior portion of this articular disc divides into the upper part that joins to the squamotympanic fissure, and the lower part joins to the neck of the mandible. And this is the intermediate zone. This is the thickest portion, the thickest zone of the articular disc, and these are generally avascular and not innervated. Whereas other portions of the articular disc are generally innervated and vascularized. So going to the other soft tissue component, that is the ligament. Generally, it has three types of ligament. The first one is the lateral temporal mandibular ligament, and it is the this is the capsule of the temporal mandibular joint, and it is strengthened by the lateral temporal mandibular ligament. So this is the lateral temporal mandibular ligament, and also the other two accessory ligaments are the sphenomandibular ligament that joins from the spine of the sphenoid to the lingua of the mandible, and the stylomandibular ligament that joins from the styloid process to the angle of the mandible. And the function of this sphenomandibular ligament is that it prevents the prevents the excessive stress of the preserves the nerves and the vessels that enters the mandibular foramen, and the stylomandibular ligament helps in the prevention of the excessive protrusion of the mandible. So this sphenomandibular ligament thus protects the blood vessels and the nerves passing through the mandibular foramen when there is additional stress during the jaw opening and closing. And but this sphenomandibular ligament plays no role in the mandibular movements. And this stylomandibular ligament, this is the sphenomandibular ligament joins from the spine of the sphenoid bone to the mandibular lingua, and this is the stylomandibular ligament from the styloid process to the angle of the mandible. And this stylomandibular ligament helps to limit the excessive protrusive movements. So this is another picture. This again showing the sphenomandibular ligament and the stylomandibular ligament. Another component of the temporal mandibular joint is the muscles of mastication, and it has temporalis muscle, the masseter muscle, the lateral pterygoid and the medial pterygoid, and these all muscles of mastication. Mastication muscles helps in the stability of the temporal mandibular joint. So the temporalis muscle, when it constricts, it pulls the temporal mandibular joint in the superior direction, and when the masseter muscle and the medial pterygoid muscle this constricts, this pulls the temporal mandibular joint to the anterior and the superior direction. And when all these muscles together with the lateral pterygoid muscle constrict together, helps in the position the mandible in the anterior and the superior position. So this position of the condyle in the anterior superior position is the most orthopedically stable joint position of the condyle. So therefore, the most orthopedically stable joint position, as dictated by the muscles, is where the muscles are located in their most anterior superior position in the articular fossa, and these are resting against the posterior slopes of the articular eminence, with the articular discs. These are properly interposed. So in order to locate the most anterior superior position, there is a procedure which should be followed. And in this position, procedure, what it is done is the patient is told to sit in the reclined position, and the chin should be directed upward, and the forefinger should be placed at the angle of the mandible, with the little finger behind the angle of the mandible, and the thumb should be placed at the against the chin of the chin of the patient, and the downward force is applied to the chin, and the superior force is applied to the applied through the angle of the mandible, and this results in the sitting of the condyle in the most anterior superior position, which is the most orthopedically stable joint position. Going to the innervation of the temporomandibular joint, the temporomandibular joint is mainly innervated from the trigeminal nerve, basically, and this is basically from the oligotemporal nerve and the mesenteric nerve, which are the branches of the mandibular division of the trigeminal nerve. And the blood supply is from the maxillary artery, deep auricular, ascending pharyngeal, and the superficial temporal branches of the external carotid artery. So the mandible, this acts as a castilever system, with the condyle as the fulcrum, the muscles of mastication as the force, and the anterior portion of the tooth as the load. And so in order to understand the temporomandibular joint disorders, we must understand the different trigger and the referred pain areas. For example, in this figure, this marked portion of this is the occipital belly of the occipitotemporalis muscle, and the trigger point of this when it is the trigger point at the occipital belly of the occipitofrontalis muscle is this refers the pain to the behind the eye, and refers the headache from pain behind the eye portion. This produces the referred headache pain, and these are basically into the behind the eye. And also the trigger point that is located in the sternocleidomastoid muscle. This refers the pain to the anterior portion of the pre-auricular area, and also to the eye, and also to the forehead regions. And also the trigger point that is located in this trapezius muscle. This refers the pain to the behind the ear, the temporal region, and also to the angle of the mandible. So in order to understand this temporomandibular disorder, it is very important for the orthodontist, and also so going to the history of temporomandibular disorder, there was a court case in 1987 when a lawsuit was filed by a patient claiming the orthodontist caused the patient to suffer with the temporomandibular disorder after the orthodontic treatment. And the patient who filed the court case was Susan Grimm, and the orthodontist was Megre. So in this case, what happened was this Susan Grimm, she was a girl of 16-year-old, and she began the orthodontic treatment with class 2 division 1 magacusan, and she had a 7 mm anterior open bite. So in her case, what the orthodontist did was he removed the removal of the upper first premolar, and they used the headgear for the treatment of the patient. And while the treatment was started, the patient had no temporomandibular disorders. Whereas after the orthodontic treatment, the patient developed the sign of temporomandibular disorder. And so after the development of the temporomandibular disorder, the orthodontist, that is Megre, referred the patient to the oral surgeon, and what the oral surgeon did was they removed the Todd Morris, saying that it was the cause for the temporomandibular disorders. Whereas, but at the same time, the patient again developed the severe temporomandibular pain, and the patient thus sued the oral surgeon as well as the orthodontist, and the oral surgeon was fined with $2,500 compensation, and the orthodontist was fined with the amount of approximately $850,000 as a compensation, which added to the and with the added cost, it was summed up to $1.3 million. So, so going to the temporomandibular disorder definition. So the temporomandibular disorder, this comprises of a group of musculoskeletal and neuromuscular conditions that involves the temporomandibular joints, the masticated muscles, and also the associated tissues. So going to the etiology of the temporomandibular disorders, this basically has various etiological factors, which includes the behavioral factors, which includes grinding, cleansing, and abnormal head posture, the social factors, which could affect the perception and influence of the response to pain, the emotional factors, which includes the depression and anxiety, the cognitive factors, which have the negative thoughts and attitudes, which can make the resolution of the illness more difficult. So going to the incidence of the temporomandibular disorders, according to Profit, this generally includes 5 to 30%, depending upon the symptoms. And according to Egermark and Erickson et al. In 1983, they said that the temporomandibular disorder increases with age, suggesting an increase in the prevalence of symptoms with up to 30 to 60%. That is 2 times between the age of 20 to 45 years. And according to Warren and Fried, they said that the females have the higher prevalence of temporomandibular disorder than the males. And the Magakusan that could have the effect on the temporomandibular disorders. This was basically summarized by Ramsort et al. In 1961, and they said that the skeletal open bite and the discrepancy between the retrograde costal position and the intercostal position of greater than 4 mm and opposite greater than 6 mm, and if there is a missing or more unreplaced missing teeth, then it could cause the temporomandibular disorders. So does the Magakusan cause temporomandibular disorders? And for these answers, we have to go to the history, and the modern history of temporomandibular disorder, this starts right from 1944 AD, where the otolaryngologist described that is Dr. James Costin. He described Costin syndrome based on the analysis of 11 cases, where he found that the loss of the vertical dimension and the deep bite due to the loss of tooth loss, this caused the temporomandibular disorder. And what he did was there was improvement of the pain, which was followed by the correction of the overbite. And when the molar support was improved, and also when the proper articulation of the condyle was done, and then the temporomandibular disorder symptoms was resolved. So the normal temporomandibular joint, this is generally characterized by the condyle, which is well formed and is well centered in the glenoid fossa. And the pathology of this glenoid fossa is generally noted when the position of the temporomandibular joint, of the condyle of the joint, is abnormally located for the prolonged period of time. So according to Ricketts, he identified the ideal position of the temporomandibular joint, which is suggested that the condyle of the mandible, this generally should be 1.5 mm from this articular eminence, and it should be generally the distance of the condyle from this fossa generally should be 2.5 mm, and from the external auditory measures should be approximately 7.5 mm. This is the ideal position of the condyle. So based on this ideal position, he classified the joint disturbances into 4 types, in which the type 1 includes the abnormal opposite, which is characterized by the class 2 maloclusion with division 1 maloclusion, where there is the excessive movement of the joint. And in type 2, there is typical class 2 division 2 maloclusion, where there is reduced movement of the joint. And in type 3, there is the interference of the movement of the temporomandibular joint due to the bicuspid and the molar interferences. And in type 4, this is generally represented by the loss of the posterior tooth. So even the slightest disharmony between the temporomandibular joint and the posterior support and the anterior guidance, this could result into the abnormal function of the muscles, and this could result into the incoordination of the muscle function. So the TMJ diagnosis, this can be classified into various categories, and this basically includes the 4 categories: the TMJ disorders, the masticatory disorders, the headache, and the associated structures. So in the TMJ disorders, it is further divided into 5 categories. It has joint pain, which includes arthralgia and arthritis; joint disorders, which includes disc condyle complex disorder, disc displacement with reduction, displacement with reduction with intermittent rocking, disc displacement without reduction with limited opening, and without reduction without limited opening. And other hypermobility disorders includes adhesions, adherence, ankylosis, which could be of fibrous and osseous type. And hypermobility disorders can be subluxation, which is due to the partial dislocation of the joint; subluxation, which is complete dislocation of the joint. And it also includes the joint disease, which includes degenerative joint disease, osteoarthrosis, and osteoarthritis. It can be condylosis, osteochondritis dissecans, osteonecrosis, systemic arthritis, that is rheumatoid arthritis, neoplasm, and synovial chondromatosis. And it also can include the fractures and congenital and developmental disorders, which generally includes aplasia, hypoplasia, and the hyperplasia. Similarly, the masticatory muscle disorders, this generally includes the muscle pain related to the orofacial region. This includes the myalgia, and in the myalgia, it can be a local myalgia. It can be myofascial pain with spreading, with referral. It can be tendonitis, myositis, spasm, and it can also, the muscle disorder also can be contracture, hypertrophy, and the neoplasm. And the movement disorders can be orofacial dyskinesia, mandibular dystonia, and it can also include the masticatory muscle pain attributed to the central and the systemic disorders, and which could include the fibromyalgia and the centrally mediated myalgia. And other type of TMJ diagnosis is the headache disorders, and this headache could be due to the headache could attribute to the temporomandibular disorder, and also the associated structure, which includes the coronoid hyperplasia. So going to the imaging of the temporomandibular joint in order to diagnose the temporomandibular disorders, this could have various imaging techniques, and one of them is the plane radiographs. And this the several plane radiographs can be projected over the temporomandibular joint so as to view the osseous portion of the temporomandibular joint. And however, this plane radiograph, this has significant distortion, and the superimposition from other structure thus prevents the thus is not the ideal technique for the imaging of the temporomandibular joint. Another method is the axially corrected tomography, and these are the two lateral projections of the condyle to view the osseous changes of the articular surface. And the images with the mouth open and mouth closed can be taken to view the range of the mandibular transgression. And the mandibular, the condylar position, this cannot be predicted from the this axially corrected tomography. Another method of imaging is the computed tomography, and these are capable of identifying both the hard and the soft tissue. And it can be used for the viewing of the TMJ ankylosis, neoplastic conditions, and the other anomalies. And the computed tomography also can be very important method when it is required to fabricate a 3-dimensional stereolithographic model. And through this three-dimensional stereolithographic model, we can the surgeon can help to fabricate the custom 3-dimensional TMJ prosthesis. The other method is the cone beam computed tomography, and this provides a high resolution of TMJ images, and it helps in evaluating the integrity of the hard and the osseous chains within the temporomandibular joint. Another method is the magnetic resonance imaging, and this magnetic resonance imaging uses the magnetic field and the radio frequency in impulses, and it is primarily used to identify the disc position, and it can be used viewed in both the closed and the open position. And it can also provide the information about the synovial fluid, bone marrow changes, bone structure at the various sections of the temporomandibular joint. And this imaging procedure is the gold standard for the identify the position of the articular disc. The another method is the arthrography, whereas in case of arthrography, the radiographic contrast medium should be injected to the TMJ, and for the injection of the radio-opaque material, it is generally painful. So injecting the contrast medium into the TMJ, which is painful, the TMJ arthrography is generally not performed for the TMJ diagnosis. And but this arthrography can be used for the disc perforation, and sometimes this condition can also be identified from the arthrography. Also, we can use the high resolution ultrasound for the TMJ imaging, and this ultrasound helps in the identification of both the hard and soft tissue, and it helps to detect the condyle defects on both the anterior and the lateral aspects, whereas the medial aspect of the articular disc, this is generally cannot be viewed from the ultrasound. This is basically because on the middle aspect of the there is the limited space between the middle aspect of the articular eminence and the condyle. The another imaging technique is this panoramic radiograph, and this is generally used as the screening image for the TMJ. It can be also used for the screening image of the maxillary mandible, sinuses, teeth, and the periodontium. And the gross degenerative changes can be seen through the panoramic radiograph. The temporomandibular disorders and orthodontics, whether it has aggression or not, it can be studied under the different headings. So whether the extraction causes temporomandibular disorder or not. So there was a study that was carried out by McAllen and Bennett in 1995, and they suggested that the orthodontic treatment with a fixed appliance with or without the extraction, this does not increase the prevalence of symptoms or signs, neither it worsens the pre-existing symptoms and the signs of the temporomandibular disorders. Also, whether the condyle position and the temporomandibular disorder. So, according to Daniel et al. In 1988, the distal pressure that is exerted on the mandible and ultimately on the condyle, this induces the temporomandibular disorder. So in the patients treated with class 2 division 1 malocclusion with extraction of maxillary first premolar, and in the patients treated with class 1 non-extraction, the condyles, these are generally located most posteriorly in the patients with extraction and quigging than in those without extraction. So the relation between the headgear and class 2 elastics. In O'Reilly et al. In 1993, they found that the orthodontic mechanotherapies such as class 2 and the extraction, these have little effect or no effect on the general temporomandibular disorder signs and symptoms. And also there is no immediate benefit or the risk for the children receiving the early class 2 treatment with bionator and headgear or the bite plane with respect to the temporomandibular disorders. Also, the relation of the Hobbs appliance and the temporomandibular disorder, this was performed by Pensers in 1985, and they found that with the Hobbs appliance, all the condyles these were positioned significantly forwards for the short period of time, but in the long period, this condyle position again returned back to the normal, and for the this causes the temporal capsulitis was present during the course of treatment, but in the long term, they did not have any potential effect of the temporomandibular disorders. So the relation of the reverse full headgear and cast elastics with temporomandibular disorders. So this reverse full headgear and cast elastics, they generally produce the distal driving force of the mandible and condyle, and thus this could produce the reciprocal forward displacement of the disc and pressure on the retrodiscal tissue, and might result in the temporomandibular disorders. So the relation of the syncope with the temporomandibular disorder, this was performed by Deguchi et al. In 1998, and they found that the spontaneous pain was mostly found during the active treatment, and also the clicking sound was occurred more often during the retention phase, whereas in the long term follow-up of the subjects treated with the syncope, they had neither a risk factor nor the prevention for the temporomandibular disorder was found with the syncope. So the relation of the cross elastics with the temporomandibular disorders. So when the cross elastics are used, there is a displacement of the mandible and the condyle on one side, and this results in the unilateral distal driving force on the condyle. And however, they can be used during the day when the resting muscles can counteract the distal driving force of the cross elastics, thus preventing the temporomandibular disorders. So can we perform the orthodontic therapy in the temporomandibular disorders? So this is orthodontic therapy is generally indicated when the orthopedic instability is present, and when we diagnose that this orthopedic instability is basically contributing to the temporomandibular disorders. And the best way to identify this relationship is by providing the orthopedic stability, and this orthopedic stability can be generally provided through the use of the occlusal appliance. And if the occlusal appliance, this does not reduce the symptoms, this orthopedic stability is not related to the symptoms, and in such case, the orthodontic treatment should not be considered. Whereas if the orthopedic stability, this results in the resolution of the pain of the TMJ, then we can, then the orthodontic therapy can improve the pain of the TMJ in such patients. So recommended protocol for the screening of the temporomandibular disorder is that, so in the screening, for the screening purpose, we should ask the various questions. And screening questions includes if they have difficulty opening their mouth, if they have if they hear noises from the joints, if they have, if their jaw gets stuck or locked or go out, and also if they have pain in or around their ears or cheeks. Also, we should ask if they have pain on chewing or wide opening. Also, if they feel that they might feel uncomfortable or unusual. We should also ask that if they had injury to the jaw, head or neck, and also we should ask about the if they had arthritis. Also, if they have previously treated with the temporomandibular disorders. And in the examination section, we can also ask, we can do the inspection of the facial asymmetry. We can ask what jaw movements. We can do the palpation of the muscle or the joint tenderness, and we can palpate for the clicking, crepitus, or abnormal movement. So this is the screening chart for the jaw function, and this I have taken from the profit. And we should mention if they have jaw, if they have TMJ complaint, and if yes or no, if they have history of pain, we should tick yes or no. We should, if there is history of sounds, yes or no. And we can also do the screening if there is tenderness to the palpation, and if there is tender, the which muscle is tender to palpation, and which side, left or right side. And also we can note the maximum opening, the excursion on the left and right side, the protrusion amount, and also we can document the deviation if there is present to the right or left side, and also at what point the deviation is present, we can also document on the history section. And for the management of the temporomandibular disorder signs and symptoms within an orthodontic practice. So at the time of presentation, and if the patient has signs and symptoms of the temporomandibular disorder, then the patient should be informed about the orthodontic treatment. This informed that the orthodontic treatment will not resolve these symptoms, these problems, and the current TMJ signs and symptoms should be noted, and the full TMJ history and the clinical examination should be undertaken and recorded. And if the existing temporomandibular disorder is acute and severe, the commencement of the orthodontic treatment should be postponed until the condition is resolved or it is stabilized. So during the treatment, if the patient developed the temporomandibular disorder, we should acknowledge and recognize the signs and symptoms of the TMD. We should reassure and educate to the patient that TMD is not necessarily a progressive problem, and in most cases will improve over time with the conservative treatment. And the active treatment should be postponed, and the TMJ signs should be postponed, and the TMJ signs and symptoms should be managed by the orthodontist, or we should refer to the TMD expert. And once the signs and symptoms can be alleviated or controlled, we can again begin the orthodontic treatment. And if the temporomandibular disorder develops after the treatment of the orthodontic treatment, the patient should be monitored for the signs and symptoms throughout the retention period. And if the symptoms arise after the treatment, then the appropriate management should be provided. So this is the example of the patient in which was having the pain on the TMJ, and it was wrongly diagnosed as the pain due to the foul origin. And in this patient, it was wrongly diagnosed, and the root canal treatment was performed on all the teeth. And finally, after the performance of all the root canal treatment, the patient had no relief of pain on the TMJ. So we should begin before doing any orthodontic treatment. Doing any treatment on the patient, we should rightly diagnose the cause of the pain in the TMJ. So orthodontic treatment therapy can only affect the TMJ symptoms if this is by generally the occlusal, by changing the occlusal contact pattern of the teeth and the resulting function of the masticatory system. And if the occlusal appliance successfully reduces the TMJ symptoms occlusion and the orthopedic stability, when the orthopedic instability is an etiologic factor for the temporal mandibular disorders. So when there is occlusal disharmony, the occlusal appliance can reduce the signs and symptoms of the temporal mandibular disorder, and the reduction of the signs and symptoms by the occlusal appliance. This is basically done by the following theories, which says that the occlusal appliance results in the alteration of the occlusal condition, alteration of the condylar position, increase in the vertical dimension, the cognitive awareness, the placebo effect, also this occlusal appliance results in increase in the peripheral input to the central nervous system, and also due to the regression to the mean, this occlusal appliance helps in the reduction of the temporal mandibular disorders. So shall we continue, or because the seminar is very long, I think we should continue in the next day.